Hello, my name is David Dombo,
And I'm Sarah Lansdowne.
and today we're going to talk to you a little bit about dissociative identity disorder, what is more recently renamed from what you'd be more familiar with of hearing multiple personality disorder.
Here we go. The name was changed due to the fact that the personalities are a fragmentation of the original personality and not a growth of a completely new one. The definition of dissociative identity disorder is a severe condition in which two or more distinct identities or personality traits are present in and alternatively take control of an individual. DID reveals a failure to integrate various aspects of the identity, memory, and consciousness into a single multidimensional self. Disassociation is a psychological process that alters a person's thoughts, feelings, or actions so that for a time a certain information is not associated or integrated with other information as it normally is, which means that each personality is a distinct being in and of itself. The other personalities may be aware of each other, but the original personality, most of the time when you first present, you are not aware that you have alternate personalities. The symptoms of DID is that an individual has to have two or more distinct personalities, and at least two or three identities repeatedly take control, and each may present with their own distinct personality and can have their own name, and they can have their own distinct personality traits, they can have their own history, their own background. They are completely separate beings. Particular identities may emerge in specific circumstances. Mostly it's brought on by stress. Alternative identities may deny knowledge of one another. They can be in conflict with one another, and they can even be critical of one another. There are frequent gaps in memory between the individuals because they remember certain things differently. One personality can remember something, and another personality has no memory of what that other personality has done. They can have symptoms of depression, anxiety, dependence, and guilt. In childhood, problem behavior and an inability to focus in school are common. Self-destructive or aggressive behavior may be present. And another one that's kind of rare is visual or auditory hallucinations. The range of reported identities is from 2 to 100, but half of reported cases have 10 or less. So it's kind of abnormal to have a higher number of personalities. The causes, DID is not entirely understood. We don't really have a concrete idea of why people present with DID, and it's sometimes and very often controversial. There does seem to be a link between having experienced severe physical and sexual abuse, especially during childhood. That's one thing that most scientists do agree on, is that it is seen to mostly be caused by trauma. Although a specific cause is not known, DID is becoming more common, whereas it used to be a very rare condition. A more commonly held belief about DID is that it is not due to direct psychological effects of a substance or a general medical condition, which just means that it's not brought on by drugs or a medical condition that somebody already has. It's brought on by an event that somebody has experienced. Some believe it's caused by a probing of a therapist, or often just the power of suggestion of the therapist saying, this is what I think you have, and so that's what they've been diagnosed with. Brain imaging, however, has corroborated the transition from one identity to another. There have been images that show that something does go on in the brain when they do transition from one identity to another. The average time that elapses from the first symptom to diagnosis is 6 to 7 years, which is another reason why DID is not commonly diagnosed and is not really understood because there's such a big gap. DID, while it is rare, it is becoming more common in today's society. The prevalence rates in just the general population is between 1% or less. Some studies have indicated that there's like 3 to 5 or a little bit higher percentage, and they do see it more in psychiatric settings. Approximately 73% of individuals that are exposed to a traumatic incident will experience a dissociative state, which doesn't necessarily mean that they're going to have DID, but they'll have something similar to it. And they'll experience it during the incident or in the hours or days and weeks following. However, most of these people that experience these states, they will subside within a few weeks after the traumatic experience. And that's where it differs from DID, because DID, they develop this identity disorder in its long term. The DSM-5 estimates the 12-month prevalence of DID as about 1.5% of the population of American adults, which is different from the dissociative states that we've talked about previously. The prevalence varies depending on how the studies are done, and it also varies depending on the different countries. There is no across-the-board percentage. It's different in every country.
So just a little bit more to expand on my colleague's prevalence slide. This is a little bit about where you see it in those countries. It's pretty much found in almost every cultural context there is worldwide. Most of the patients that are found are usually reported in outpatient psychiatric or even inpatient psychiatric wards, and also emergency departments is another common place. Kind of looking at it from a global perspective, and at least in Western civilizations and say North America, it's prevalent, or it's rated to be anywhere between 4 to 5.4% of psychiatric inpatients will meet criteria for DID, or dissociative identity disorder. It gets a little higher in Turkey, about 5.4% of the same type of population, psychiatric inpatients. And then also 2.8% of those will have substance dependence, not necessarily usually as a result of them being dissociative identity disorder patients and dealing with their depressive symptoms. They turn to drugs for that. A little bit more, you'll see a much higher observed rate in emergency departments for acute psychosis and things of that sort. It's been reported in Istanbul, 14% in 1 year of observed outpatients in the emergency department had dissociative identity disorder. And in New York, New York had the highest percentage in North America at 6% in their outpatient psychiatric units. A little bit more, all the countries, like I was saying, pretty much everywhere is going to have this. It's just a matter of, defining that culture and seeing different personalities kind of come out within each country. All the countries that have reported cases of dissociative identity disorder or multiple personality disorders: Turkey, Puerto Rico, the U.S., UK, Japan, Australia, and tons of others. Most of it is intrinsically related to experience of self and personhood. There's different manifestations in different cultures. For instance, in the West, there's more focus on the self and in the individual. So you'll see more personalities emerge that are of an independent of one another personality within the same person. So they will have their manifestations are going to be different from what you would see, say, in Europe or in Asia, where there is more emphasis on the interdependence of each other. So you'll see people kind of forming their personalities based on expectations of those around them. Kind of like if they were to switch groups, you'll you'll see one personality emerge amongst their professional life, and then another personality emerge amongst different social aspects of their lives and what they may even present to their families with.
People with DID, most of their coping mechanisms are related to therapy. Some keep journals so that they can try and keep track of where their identities are going and what they're doing and how they interact with the people around them. Most of their coping mechanisms are just trying to keep track of the different identities and what they're doing and how to interact with society with the different identities. But the major thing about DID is it in and of itself is a coping mechanism. People with DID develop DID because their psyche can't deal with the emotional trauma that they've experienced, and so they develop different identities to deal with what has happened. The alternative identities emerge within a person when they're placed in a situation which is mostly caused by stress, and when they can't deal with it, the other identity will come out as a way of trying to protect the original personality. A lot of times, DID is associated with protective personalities. Other treatment that's talked about later in the presentation is mostly due to therapy and just trying to cope with the different personalities. But there is no specific coping mechanism that DID patients have to deal with their disorder other than therapy and just dealing with the different personalities.
So this was kind of an interesting find as far as one of the major studies looking at DID. It was found that many patients who will present with DID may also have a lot of other co-occurring issues going on. One of those in particular, the largest one being borderline personality disorder, which is a little bit different. Similar manifestations, similar reasons for it developing, but it can present a little bit different. The biggest thing that differentiates dissociative identity disorder from BPD is the fact that its major symptoms, like identity confusion, not knowing that each other is there, or even those personalities might know that each other's there, but they'll just be confused of each other's roles at the time until they start going into therapy. Identity alteration, literally changing who they are day to day, and also amnesia, forgetting person, place, time, where they've been, what they've done. Are the core symptoms that differentiate DID from almost everything else. Another big one that's been reported by more research, mainly from Japan and Australian studies, is the concept of derealization and depersonalization in life are also very large cofactors that separate everything. But these studies on co-occurrence have found that many patients who experience or who present as DID will also show BPD, and many of those times will also show dependence abuse and a lot of related background information being sexual and physical abuse when children. So when will I see this as a paramedic? Not very often. This is, as the epidemiology studies and prevalence studies show, it's very, very rare, very ill common to see and present. You might see it during a transient crisis if someone is having a large stressor in their life. Say they're applying for a major job right after an exam is coming up and they're terrified for their lives and they have DID but haven't been told they have it yet. They might freak out and a new personality may emerge and you'll have to take care of that. Treat them with Haldol if they seem psychotic or something like that. A lot of the times you might also see this if you're in a transport service like RTS or something and you're doing interfacility between psychiatric wards would be another big chance.
You can also see it just in a normal person who knows they have DID. If they injure themselves, they can be perfectly fine until they call paramedics and you have a bunch of people on scene and they can't deal with the stress of so many people being near them that a personality can come out to protect them. So you can just see it in somebody that has a DID due to the stress of just what's going on around them.
And the last big thing to add on this one is whenever you would see them in their psychosis, crisis per se, a big reason that DID is misdiagnosed is because it can present as schizophrenia upon initial, evaluation if someone's never been told they have it before. So that's another big problem and another big reason why its prevalence and epidemiology is so low. So what am I going to do in the truck? Well, communicate. Don't be scared. They're not usually nonviolent. They're not going to freak out and try to hit you. They might just be really scared and stressed. Just talk to them. Get them to open up. Speak about their life. Speak about what's going on. If you notice that they kind of daze off and kind of change and not necessarily are responsive, well, they might even be going through a personality change based on the different stress and environment that's going on. So just kind of, be ready for it. Don't freak out. They're not going to die on you immediately unless they have some sort of trauma. Treat them like you would any other patient. Go through your full history, whatever you can get. Any bystanders on scene, any family members may be able to tell you a lot more if they have been diagnosed and have been working with them. Let them talk. Give yourself a little more time in the truck and just be nice as you would to anybody else.
Um, Also, make sure that when you have somebody who has DID, if they do change personalities, you also have to be aware that they're distinctly two different people. They can be distinctly two different people. They can have completely different names. They'll have a completely different history. They'll tell you completely different stuff. Your original personality could tell you that, they were born with no medical problems and don't take any medications or anything like that because that's what they believe, and then your next personality can tell you something completely different. So you have to make sure that you treat the personalities as two distinct people, but also make sure that you're aware that a lot of your information can be wrong if your patient changes personality.
So last big thing we're going to go over is a case study. Pretty famous case, big deal on Ohio State University's campus. Man by the name of William or Billy Stanley Milligan. He's famous for standing trial for being accused of rape on Ohio State University campus. Three separate women, and each woman described a completely different personality upon standing trial and testimony for who it was that raped them, even though it was the same person. One person described the attacker and the rapist to be a very heavy German accent gentleman who uh, talked about communism and things of that sort and craziness. And then the other person described, the other two people described another alternate personality, which the two ladies said that he was very nice and a very genuine kind of guy, but aside from the fact that he abused and raped them. But his story became pretty famous. A book was written called The Minds of Billy Milligan, and then a movie was made and played by Leonardo DiCaprio, directed by James Cameron, called A Crowded Room. So the story goes, his life story is a little similar to what you might see in DID patients. He had to deal with his father killing himself early on in life. His father had 4 children, and William was the third. And then he had another, it was a stepchild later on, but his father killed himself before he was 5 years old. He tried once before with drugs, but he was saved and there was interventions made. So then he locked himself and killed himself with carbon monoxide somehow. It didn't really say exactly what he did, if he sat in a garage or not. But before he was even 5 years old and before this happened, he had already started to show 3 separate personalities as reported by those around him. Then his mother went on to remarry. They moved to Ohio from Florida after his father killed himself, and she met a man who named Chalmer Milligan, who sexually and physically abused him throughout the rest of his life living with his family up until he decided to leave. So what happened? Well, while he was in Ohio, he, as I said before, raped 3 women under 2 separate personalities. The first one being Reagan, a Yugoslavian communist with a heavy German accent, and the other being Adelana, a 19-year-old lesbian in search of affection and attention, to rape the other 2. And like I said, they completely, had different accounts of who this person was. It was the same physical person, but a completely different personality. Upon his lawyer's evaluation of him and upon doctor's evaluation, they determined that he had DID and pleaded insanity. He was eventually charged as not guilty and committed to mental health institutions for about a decade. This was a landmark case, as in the first person to be let off of charges due to dissociative identity disorder for a violent and criminal act such as this. It was reported that he had roughly 21 personalities, with the big 10 as the main ones that he would present with on a daily basis that you would see. He was a very good artist, actually. He had a lot of drawings, a lot of really dark and deep drawings, but this is one in particular that he made that is describing 7 of the personalities that he had. Reagan being the tall, dark gentleman with the Fu Manchu mustache as the one who committed the first rape, and the little girl that's being held is the Adelana, the 19-year-old. She started as 3 when he was young, and then it's developed and grown as he grew as well. But he also had 11 other identities, and these were considered the undesirables. They didn't necessarily manifest a lot. They didn't necessarily present all the time, as the Big 10 were all apparently aware of one another and kind of knew of the other undesirable personalities that he had, and didn't necessarily let them take control of his mind a lot, so that the Big 10 were the ones that would keep in control and kind of run his mind. So what did they do to try to fix this guy? Well, the biggest part of treatment for DID is to stabilize a person, make them safe, make them kind of get away from the depressive symptoms, kind of get away from substance abuse if they suffer from abusing drugs because of their depression, and also to merge the personalities, to try to start to combine themselves into one core personality, so that that can be the dominant trait that you'll see, and they won't have their manic states. So it took a bunch of doctors to work on him. The 3 big ones that helped him was Dr. Wilbur, who determined that he had DID and he needed very specialized help after a few years of going through other unhelpful institutions. And then Dr. Harding, who he was referred to at a specialized mental health institution, who began his merging of personalities. And then Dr. Call, the very last one, to help fully stabilize him in his last stage of treatment. As I kind of hinted at, there's many stages that are involved in fusing these personalities into getting a person to being more normalized, and it's usually in a series of 3 stages, as I will go into. Mainly, like I said, starts with trying to establish some safety, stability, make sure that that person's not going to be violent anymore. A lot of people, once they hit that first stage, they end up stopping, though. It's very uncommon that you'll see people progress past the safety and stability stages. The next ones is more of, kind of therapy sessions where you explore yourself, explore your feelings in very controlled ways to try to bring out some emotions, bring out some of those personalities, and start to kind of merge the more similar ones together. If one stays with therapy, then the last big thing that they'll do is they'll actually have a more intensive stage where they kind of don't sugarcoat it and force you to see yourself. They may record one personality and then show the other personality, so that you can be aware of it and you can see what yourself is doing once you're in your more normalized state. And this can take time. This can take many years. For him, it took over a decade to become more normalized. They had to start by merging more similar personalities and identifying all of the ones that he had and all of the undesirable ones. But once they were able to get all of his personalities converged and merged into one, or more of the big 3, as they called it, he came back down to just 3 personalities at the end of his therapy sessions, with one of them in particular being called the teacher, that all of the other merged personalities looked up to as being the decision maker, the guidance of his daily operations. And that was really a very interesting case, very big story, very big deal. It was believed that 3 different things caused him to become dissociative in identities. There's a psychodynamic perspective, which is relating to the sexual and physical abuse that he received as a child. It's also believed that there was a socio-cultural perspective, basically from where he was living, his life at home, his family, all the moving, all of the institutions that he was in, all the different doctors he saw who misdiagnosed and had to, really evaluate him to see and believe that DID was even in existence. And then the last one being a cognitive perspective, which is probably the largest part, which is basically what happened within his mind and what he went through during these stressful times and the different personalities that emerged as a result of what his environment was doing.
And these are our references.